affect your prognosis. So in case of reversible pulpitis, you will get a favorable response from the pulp because there are no necrosis in the pulp that could inhibit the healing process of the pulp, while in case of irreversible pulpitis, you have necrosis in the pulp, a necrotic area. This necrotic area will inhibit the healing ability of the pulp and will still as a foci for continuous infection to the pulp. The second prognostic factor is bleeding time. We have said that continuous bleeding or presence of necrosis in the pulp chamber are poor prognostic factor. Third one, capping material, hydrolylated calcium silicate versus the aqueous calcium hydroxide. There are difference in their outcome. The skill of the dentist, ability to identify and handle inflamed tissue. This needs skill from the dentist. And use of disinfecting agent also can affect the prognosis of direct pulp capping. Use of operating microscope significantly increase the chances of success in case of direct pulp capping. Extent of caries process, restorability of the tooth and sealing ability of the restoration are very crucial and important in order to have a good outcome. Aseptic procedure versus the classic procedure using rubber dam is very important to assure that we are doing well and we expect good prognosis with direct pulp capping. The procedure is well known for you, but there are some points we need to focus on it. First of all, confirm the pulp condition pre-operatively and intraoperatively after the exposure by using sensibility test. Isolation with rubber dam, non-selective caries tissue removal, meaning that remove all caries dentine around the exposure site. Magnification should be used throughout the procedure to ensure removal of all soft dentine and to inspect the pulp tissue in an easy way. Removal of superficial inflamed pulp tissue if necessary, and this will be similar to partial pulpotomy, but it's not at the same extent of partial pulpotomy. So a small piece of the inflamed pulp tissue, you can remove it with high-speed bare, with sterile high-speed bare and water cooling. Hemostasis and disinfection are very important. Usually we use sodium hypochlorite solution 1% or chlorhexidine. And this should be achieved using a cotton pallet soaked ideally with sodium hypochlorite or chlorhexidine. If pulpal bleeding cannot be controlled within 5 minutes, then perform partial or complete pulpotomy. A hydraulic calcium silicate cement should be placed directly onto the pulp tissue and tooth definitely restored immediately to prevent further micro leakage. Many studies have found that direct seal and doing permanent filling on a direct pulp exposure can give a good response and increase the chances of success. So the outcome of direct pulp capping in cariously exposed mature permanent teeth. Previously, direct pulp capping was expected to do bad in cariously exposed mature permanent teeth. And this because of there are 2 studies in Europe that show a poor outcome and poor numbers of success compared to other modalities of treatment, compared to partial pulpotomy or complete pulpotomy. So these 2 studies, the first one is by Barther et al. And they follow the teeth for 5 and 10 years after pulp capping of carious exposure in a dental school. So the students do the direct pulp capping, and they follow it for 5 and 10 years, and they found that the success rate after 5 years was 37% only. Of course, they use calcium hydroxide only. And after 10 years, they found it is 13% only. So it's a very low number of success. That's why direct pulp capping on a cariously exposed mature permanent teeth was contraindicated. The placement of a definitive restoration within the first 2 days after pulp exposure was found to contribute significantly to the survival rate of these teeth. However, this may be the very low success rate may be due to that student who performed the direct pulp capping. It's not an experienced endodontist or experienced dentist, but the students that have a very low level of experience. Another study in 2010 by Biondal et al. And we found that with exposed pulp were randomized to direct pulp capping or partial pulpotomy, we found no significant difference in pulp vitality without apical radiolucency between the two capping procedures. So after 1 year, they found that the pulp capping is 31.8%, and the partial pulpotomy was 34.5%, which are very low percent of success, and does not encourage to perform these treatment modalities on a cariously exposed mature permanent teeth. So these are two main studies that societies and dentists or clinicians depend on to justify their decision not to do a direct pulp capping on cariously exposed mature permanent teeth.
دكتور أحمد
Yes.
عفوا اكو سؤال تحب نسأله هسه لو بعدين بنهاية
لا على راحتك as you like دكتور.
There's a question from Dr. Samer.
Yeah.
He write it down that for how long you apply the sodium hypochlorite or chlorhexidine solution to the exposed side before capping? How long do you recommend?
Well, it's for 1 minute, just to disinfect and make the pulp hemostasis. So just to ensure the hemostasis of the pulp.
Okay, it's for the as a hemostatic agent and as a disinfectant.
Yes,
or
both of them. Yes, both of them. Yeah.
Okay.
So once you get hemostasis, in that case, you don't need it anymore, but you should measure or calculate the time you need it for hemostasis.
Okay.
Yeah. So this a systematic review by Aguilar, which is very very famous, and they found that the success rate of direct pulp capping was at 6 months to 1 year was 78.5%, and from 1 year to 2 years it was 95.4%, and from 2 to 3 years it was 87.7%, and more than 3 years it was 72.9%. So it's a fluctuation. There is a fluctuation in the outcome of direct pulp capping. While in case of partial pulpotomy, it was very clear that the success rate is very high. It reached 97.6% at 1 to 2 years, and go on for partial pulpotomy. And for full pulpotomy, it was 94% and 94.9%. So the success rate of partial and complete pulpotomy, it was very clear, more than the direct pulp capping. So direct pulp capping procedure using calcium silicate cements, which is a new advancement, a new material, and this may shift the favor of successful outcome. So we have this study by Bugin et al. And they found that in 2008, they found that the success rate, it was 97.96%, had a favorable outcome. And this was direct pulp capping in cariously exposed mature permanent teeth. Another study by Lino et al. In 2017, treatment outcome following direct capping using bioceramic material in mature permanent teeth with caries exposure. And they found that the success rate with MTA was 84.6% and 92.3%. Diffuse calcification of pulp chamber were observed in 7.7% of cases with MTA and 23.1% with biodentine. The biodentine probably induce more calcification than MTA because there is another observation. They found that radiographically visible dentine bridge formation was observed in 70% in MTA and 61.5% cases with biodentine. But the diffuse calcification in the pulp chamber was more in the biodentine. And I remember my colleague Dania, which did a clinical trial using biodentine as well. She did found a lot of dentine bridge or a hard dentine area or a radiographically calcified dentine under the biodentine material. And this was very interesting. Another study by Marquez in 2015, and they found that the overall success rate was 91.3%, which is very high. And they found that, conclude that direct pulp capping with MTA after pulp exposure during excavation of deep caries could maintain pulp vitality in permanent teeth. Another one by Menti, and they found that the success rate, they compare calcium hydroxide with MTA, and they found that there is a huge difference between the two procedures, and the success rate for MTA was 80.5% compared to 59% only in calcium hydroxide. So let's talk about partial pulpotomy. So we can conclude that direct pulp capping is successful if we use a calcium silicate cement in cariously exposed permanent teeth. Partial pulpotomy, which is removal of part of the pulp, and this small part of vital coronal pulp is to remove the expected inflamed tissue from the pulp in order to preserve the remaining coronal and radicular pulp tissue. The coronal pulp is reduced from the exposed side by approximately 2 to 3 millimeters in order to remove necrotic or potentially inflamed and irreversibly damaged tissue, keeping the remaining pulp vital. After partial removal, if bleeding cannot be controlled within 5 to 10 minutes of direct exposure to sodium hypochlorite, the complete removal of the coronal pulp to the pulp floor or pulp chamber floor is the preferred option, and the amputation site is covered with sodium hypochlorite socket cotton pellet until hemorrhage ceased. A calcium hydroxide suspension or calcium silicate cement is applied to the newly exposed pulp surface and covered with a cement for the calcium hydroxide suspension or a thin layer of flowable composite, or compomer or resin modified glass ionomer. The rationale, I think I have mentioned yesterday, that the histological studies have shown that there is an evidence that the inflammation is confined to a limited area of the pulp within the exposure site, and it is not uncommon to find normal histology architecture in the coronal pulp away from the caries. And not all the cases diagnosed with irreversible pulpitis demonstrated irreversible changes histologically. There are 15.4% of the cases with the clinical signs of irreversible pulpitis, they have a normal histological feature, and it's just a reversible pulpitis or normal pulp. So this will make the rationale to do a partial pulpotomy and not depend on just the clinical diagnosis, which tell you that it's irreversible pulpitis, because there are 15.4% of the cases with irreversible pulpitis have normal texture. So this is a meta-analysis and systematic review about the partial pulpotomy. And it's showing that success rate is about 98%, which is very high. And there are 92% after 6 months and 1 and 2 years of the follow-up. So it's a 98%, 96%, and 92% after different time interval, after 6 months, after 1 year, and 2 years. So it's very high success rate. And again, this is a partial pulpotomy in curiously exposed posterior permanent teeth.
Dr. Ahmed.
Yes.
We have a question from Prof. Adil Farhan. Yeah. He said, what is the protocol the studies follow to evaluate the success rate of direct pulp capping and partial pulpotomy?
Yes.
Depending on what? Clinical signs and symptoms only?
No. This is not acceptable, because you have to confirm your clinical signs, symptoms, and your pulp sample sensibility test and your radiographical outcome or radiographical examination. So you have 3 categories or 3 parameters to assess the success of a specific treatment. In dentistry, we have these 3 parameters that we depend on it in different situation and everywhere to assess the success of the treatment. So you have asked the patient about the symptoms, if he got symptoms right now or previously, and you do a pulp sensibility test with it to assess your judgment of the condition of the pulp, and then you take a radiograph and assess the periapical health or disease. So these 3 parameters need to be followed to assess any outcome of any treatment. Is that clear? Hello?
Yes, Dr. Ahmed.
Yeah,
Fair
okay.
enough, yeah.
Okay. So in these cases, or in this meta-analysis, they found that irreversible pulpitis display a significantly lower results. The available data suggests that a partial pulpotomy result in high success rate in treating curiously exposed permanent posterior teeth up to 2 years. Another randomized controlled clinical trial, but they use MTA in that case with partial pulpotomy. And they found that the success rate after 1 year, there was no significant difference in the outcome treated with the 3 MTA materials. So the ProRote MTA give 96%, Ortho MTA 92.8%, Retro MTA 96%. And the radiographic cumulative survival rate, in addition, no potential prognostic factors related to the success rate of partial pulpotomy, like the age, sex, tooth type, root apex status, and the site and type of pulp exposure, and the type of restoration were observed in the log-rank analysis. So they do different statistical tests, and they should mention the statistical set they use to assess these prognostic factors, and if they are affecting the outcome or not. So let's talk about the partial pulpotomy for teeth with signs and symptoms of irreversible pulpitis. So the previous one was only for partial pulpotomy for carious exposures. But what about the signs and symptoms of irreversible pulpitis? Again, it is the clinical one. So a study by Taha et al., which is very famous and published in Journal of Endodontics. The aim was to assess the outcome of partial pulpotomy using mineral trioxide aggregate and calcium hydroxide in mature cariously exposed permanent molars. The clinical signs and symptoms are suggestive of irreversible pulpitis. in all the teeth. And they found that at 1 year, MTA showed a higher tendency towards success compared with calcium hydroxide group. And the difference was statistically significant after 2 years. So they found that the MTA gave 83% against 55% in the calcium hydroxide. And they found that 6 did not have statistically significant effect on the outcome. So from this, we can conclude that a treatment of irreversible pulpitis can be performed using partial pulpotomy. So MTA partial pulpotomy sustained a good success rate over 2 years, which is medium time. It's not too long or not too short. 2 years follow-up in mature permanent teeth and clinically diagnosed with irreversible pulpitis. And more than half of the calcium hydroxide cases failed within 2 years. The problem with calcium hydroxide and compared to MTA is the solubility of calcium hydroxide. The most important thing in exposure or treating the pulp exposure or partial pulpotomy, which is similar to pulp exposure in a certain way, but it's bigger, is the solubility of the material that we cover the MTA with it, the pulp with it. So the MTA have good stability compared to calcium hydroxide, which is very soluble. This is a video showing you the procedure of calcium hydroxide. The procedure of partial pulpotomy in a teeth with irreversible pulpitis. This is done by Dr. Riccocci, which is very famous and as a clinician and a histopathologist. What I like about the videos of Riccocci, he is combining the histopathology and the clinical settings. So he got a lot of knowledge about this subject, and he got a lot of cases, and he published a lot of the articles dealing with this subject. So please see the video and enjoy it. Please tell me if the sound is not clear.
This is a 48-year-old woman seeking treatment for spontaneous pain in the left upper jaw.
صوت ناصع شوية دكتور أحمد.
Deep interproximal.
لحظة.
This is a 48-year-old woman seeking treatment for spontaneous pain in the left upper jaw. The two premolars had deep interproximal caries. Following examination, diagnosis was irreversible pulpitis for both teeth. According to the guidelines by the International Endodontic Associations, when clinical diagnosis for major teeth is irreversible pulpitis, the only treatment option is root canal treatment. In this case, an attempt to save vitality of part of the pulp was undertaken. Carious tissue excavation reveals pulp exposure. This tissue is partly avascular, indicating partial necrosis. Meticulous removal of soft tissue in the cavity floor is accomplished. Partial pulpotomy can now be performed. The pulp chamber roof is removed together with a superficial layer of the pulp tissue. Same procedure for the second premolar. Irrigation with 1% sodium hypochlorite. The pulp doesn't show optimal conditions. Successive layers of pulp tissue are progressively shaped off. Again, irrigation, hemostasis, until hemostasis is obtained and you get a clean, homogeneous, red, blood-filled pulp tissue surrounded by clean and sound dentin. The pulp wound can now be covered by a biocompatible material. Pre-mixed bioceramic materials are a good choice. The cavities are temporarily restored with a flowable composite to allow setting of the bioceramic material. After 24 hours, cavities are reaccessed and setting of the bioceramic confirmed. Because this is an experimental procedure and re-entering is scheduled in a 3-month period, build-up with composite materials was accomplished at this point, leaving an occlusal access cavity filled with IRM. A post-operative radiograph is taken and the patient instructed to report any discomfort in the successive period. The patient returned after 3 months, declaring that the teeth had been comfortable. Temporary IRM fillings were in place with minimal margin deterioration. The pulps responded weakly to a cold stimulus applied to the cervical area. Radiographs showed normal periapical conditions and absence of irregular calcifications in the root canal space. IRM was removed and the bioceramic exposed. Its hardness was checked and the material carefully removed with low-speed tiny bursts and a DG16 probe. This revealed a homogeneous layer of newly formed mineralized tissue, repairing the entire surface of the surgical wound and isolating the underlying pulp tissue. Gentle probing of this mineralized tissue confirmed its uniformity. The same procedure is followed for the second premolar, where identical responses were observed. The pulpotomy procedures had been successful for both teeth. The mineralized bridges are covered with a calcium hydroxide base and the access cavities restored with composite systems. Cast protection is recommended for these teeth. Follow-up radiographs taken after 6 and 14 months show normal periapical conditions and absence of pathologic calcifications in the canals. The clinical treatments shown in this video are based on the following publications.
I think the video is finished. So let's move on with our lecture. Is there any questions?
دكتور أحمد صوتك شوي ناصي.
Sorry. I'm saying, is there any questions?
دكتور أنا عندي سؤال يعني هو هاي من after the period of waiting for the calcified tissue, why he removed the calcium hydroxide.
Oh, well.
He just want to show us, or this is an experiment?
This is experimental.
Okay.
Experimental, just to show the others or the viewer that there is a mineral tissue formed over the pulp. So because it's experimental, so he did that.
So it's not recommended to remove any of this material?
No, there is no need at all.
Okay.
Yeah. Sorry, this is another video. He using calcium hydroxide instead of bioceramic sealer. Again, as a partial pulpotomy procedure for tooth with irreversible pulpitis.
A 15-year-old boy was referred by his general dentist for root canal treatment of his mandibular first molar with a deep occlusal caries lesion and the diagnosis of irreversible pulpitis. Sensitivity tests gave exaggerated responses, but the tooth was not tender to percussion. A radiograph showed that caries had reached the mesial pulp horns, but no periapical disturbances could be observed. The patient and his parents were informed that an attempt to maintain pulp vitality through a pulpotomy procedure could be undertaken. After anesthesia and rubber dam isolation, the cavity is enlarged and soft carious tissue grossly removed with low-speed burrs and a water spray. After first excavation, caries is still present on the cavity floor, and this is removed with hand excavators. The cavity is rinsed with 1% sodium hypochlorite. Pulp horns are exposed, but carious tissue is still present. After more vigorous excavation, large areas of the pulp are exposed, with dentin chips displaced onto the pulp tissue. Next step is partial pulpotomy. Segments of the roof are removed and layers of the pulp shaved off with high-speed burrs. Hemostasis is obtained. The pulp wound exhibits ideal conditions for capping. The wound is covered with chemically pure calcium hydroxide powder gently adapt to the wound. Avoid pressure. Excessive powder is removed, the capped wound covered with Dykal, and the cavity temporarily restored with IRM. A post-operative radiograph is taken. The patient is advised to come to the office anytime in case of pain. At the scheduled appointment, 3 months later, the patient declared that there was no post-operative pain and that the tooth had been comfortable for the whole period. The tooth responded normally to pulp tests. The radiograph showed some mineralization of the wound surface in the pulp chamber, absence of calcifications in the root canals, and no periapical disturbances. After anesthesia, the tooth is isolated. Note that the IRM is in optimal conditions. The temporary material is removed. Note the dark debris washed away from the pulpotomy area, likely remnants of the blood clot. Mineralized tissue filling the pulp once appear. Careful probing reveals that the tissue is continuous, although irregular. This newly formed tissue is protected with Dykal. And build-up of the crown completed with composite materials. Given the weakness of the crown, cast protection is advised. Follow-up radiograph taken 3 years later shows absence of pathologic changes in the pulp chamber, in the root canals, and in the periapical region. Interproximal enamel caries can be seen. Although the composite restoration is in good conditions, the presence of incipient interproximal caries highlights the necessity of urgent cast protection. The clinical treatments shown in this video are based on the following publications.
So as you have seen that vital pulp therapy in irreversibly inflamed tissue, if it is done with caution and following a biological approach, this will give a high success rate and will prevent the devitalization of teeth and prevent the consequences of devitalization and may increase the survival of the tooth. The current recommendation is to see the cost effectiveness and compare it with root canal treatments. So we will see the papers recommend that, and we will follow our lecture right now. So vital pulp therapy, which is the paper by Rigocci, and this is based on histopathology and histobacteriological analysis or guideline to treat teeth with deep caries. So we found that he concluded that vital pulp therapy following the guideline proposed in the present article has the potential to improve the outcome of conservative treatment of mature teeth with deep caries, and in some occasion may be an alternative to pulpectomy. So he followed the guidelines. You see it in the video in terms of bleeding time, in terms of magnification, and see the response of the pulp tissue and where to cut to diagnose the necrotic area, in addition to clinical diagnosis and in addition to radiographical analysis. So you will get a favorable outcome from these treatments. So this is one of the cases I want to show it to you from Rigocci et al., the same paper. And the clinical diagnosis was irreversible pulpitis. And if you can see the pulp chamber, the irreversible pulpitis is very clear because you have a necrosis in the pulp that make the pulp as an irreversible entity or irreversible situation. And you can see pulp stone as well. And you can see these black dots, which are the bacteria. And after magnification of this area, we can see that the bacteria have penetrated through the dentinal tubules and reached the pulp, causing a necrosis area. So this is irreversible pulpitis, but as you can see, the rest of the pulp is clear from any inflammation or infection. So in that case, treatment by removing the irreversibly inflamed part could preserve the pulp and prevent its removal or devitalization, and preserve the vitality of the tooth. As you can see here. And this is another case in which the clinical diagnosis was irreversible pulpitis. Again, a deep caries lesion in a molar. And after caries excavation, non-selective caries excavation, you will find that there's a yellowish avascular tissue that was indicative of partial necrosis. So redness of the area is very important to assess that there is a circulation in the area and it is vital, and there is no need to cut from it, in addition to other parameters. So he proposed that deep caries, teeth with deep caries, can be either diagnosed as a reversible pulpitis or irreversible pulpitis. In case of reversible pulpitis, if you have a pulp exposure after non-selective caries removal, which I think he exaggerate his statement that he need to do non-selective removal for all cases with deep caries. He does not believe in selective removal, because he think that, because he is a histopathologist and he see that these area, which is the tertiary dentine, usually invaded by bacteria, even in case of partial caries removal or non-selective caries removal, or sorry, selective caries removal. He found that the bacteria is still there even after selective caries removal. So he don't believe in selective caries removal. He just believe in complete excavation of caries, even the affected area, which is the leathery dentine or firm dentine, and reaching the hard dentine. So after, in case of pulp exposure, if there is pulp exposure, yes, so you look for sound dentine around the exposure and continuous blood-filled pulp, not a necrotic piece of the pulp, a bleeding control within 2 minutes, and there is no dentine chips displaced in the pulp exposure site. And if these conditions are present, then in that case, you go for direct pulp capping with biocompatible bioactive material like bioceramic, MTA, or biodentine. If you did not get these factors or these conditions, in that case, you go for pulpotomy. And in case of there is no pulp exposure, so sound dentine at the bottom of the cavity restoration with or without bases. And in case of irreversible pulpitis with deep caries, your clinical examination or clinical diagnosis was a reversible pulpitis. In that case, you go for pulp exposure, which is mostly happen in cases of reversible pulpitis. And in that case, you go for you look for continuous pulp tissue and bleeding control within 2 minutes. If that happened, then you go with pulpotomy. If you didn't get these, then you go with pulpectomy. He using strict criteria to perform pulpotomy or direct pulp capping. In case of complete pulpotomy, the removal of the coronal portion of the vital pulp as a mean of preserving the vitality of the remaining radicular portion. And this may be performed as an emergency procedure for temporary relief of symptoms or therapeutic measure, as in instance of Zwick pulpotomy. So it's similar to partial pulpotomy, but in that case, we remove the pulp tissue to the level of the orifice of the root canal. So the entire coronal pulp is removed and the vital pulp tissue kept at the entrance level of the root or of the canal orifice. And after successful hemostasis, it's treated analogously like direct pulp capping by putting bioactive material over the orifice in order to cover the remaining radicular part of the pulp. Bleeding time consideration. The ability to control bleeding after amputation of the infected pulp has been suggested as a surrogate marker for degree of inflammation and healing potential. Therefore, it may drive the clinician choice between partial and full pulpotomy or root canal treatment. And as we have agreed that, we call it the intraoperative assessment, which is very important and very crucial. So treatment outcome of permanent teeth molar with irreversible pulpitis using biomaterials. And this is done by Asghari, I think in 2011. And they found that the clinical and radiographic success rate of complete pulpotomy was 98% as a clinical success and 95% as a radiographical success. This is for the material, the PMTA, and the other material is the PCEM. And the success rate for CEM was 97% and 92%. So they are comparable in success rate. And this is a very high success rate in cases with irreversible pulpitis. So it's quite promising. And they conclude that excellent treatment outcome occurred in molar teeth with irreversible pulpitis undergoing pulpotomy with MTA or CEM biomaterial. Another study. Naam. Yes.
How long do you still have?
Sorry?
How long in your lecture do you still have?
Not too much.
Do you think you need to have a break for 10 minutes?
No, let's complete and then take the break. Okay? If that's okay for you.
That's okay.
Okay. So pulpotomy for carious pulp exposure in permanent teeth. And again, we see that the pulpotomy is a prospective substitute for root canal treatment in managing permanent teeth with carious pulp exposure, even in permanent teeth with irreversible pulpitis. This is a systematic review and meta-analysis on 2019. So there is a decision that pulpotomy, and this is in the Journal of Dentistry, that the pulpotomy could substitute root canal treatments and management of permanent teeth with carious pulp exposure, even if there is an irreversible pulpitis clinical signs and symptoms. The success of pulpotomy in managing irreversible pulpitis challenge the rhetoric that irreversible pulpitis can only be managed by root canal treatment. However, they look for cost-effectiveness analysis rather than analysis on effectiveness. So the effectiveness of pulpotomy is already confirmed, but the analysis of cost-effectiveness need to be done. Also complete pulpotomy and irreversible pulpitis and PA involvement. A pulpotomy is performed in a tooth with extensive caries, but without evidence of radicular pathology. However, this is according to the ESE recommendation, but the guidelines requiring the absence of apical pathosis need to be, it's outdated and require modification. There is a growing evidence from contemporary studies show that resolution of radicular lesion after pulpotomy treatment using the new calcium silicates diagnosed with irreversible pulpitis. So we can treat teeth with irreversible pulpitis and also have a periapical pathosis. This is a very old study. I found it in 1995 by Kaliskan, and he did a 26 teeth diagnosed with irreversible pulpitis and periapical radiolucencies, and 24 teeth have been successful clinically and radiographically after 36 and 72 months with no signs and symptoms or periapical involvement, which is very interesting. So the question Sorry, this is another, I want to show it for you, which is the study I told you that they do a randomized control clinical trial of 2 arms, a study of 2 arms, one arm with root canal treatment and the other arm with pulpotomy. And they found that the success rate was 71.3% for vital pulp therapy, which is the pulpotomy, complete pulpotomy, and 56.8% for RCT after 5 years, which is interesting. The outcome and patient age were not significantly related to each of the defined age groups. And for the interaction of treatment type and preoperative periapical involvement of the teeth on the treatment success and failure, the multiple binary logistic regression model revealed no significant difference, meaning that presence of preoperative periapical involvement does not affect the success or failure of the procedure. Meaning that teeth with reversal pulpitis and preoperative apical lesion can heal with pulpotomy or root canal treatments. And the success rate was very close to each other and comparable. So the question arises from this randomized control clinical trial: why we do root canal treatment for these teeth if we can do vital pulp therapy and give the same success rate? This is the outcome of full pulpotomy using biodentine. This is done by Taha. And they found that after 2 days, 93.8% reported complete relief of pain. This is done by complete pulpotomy, not partial. And the clinical and radiographic success at 1 year was 100% for the clinical and 98.4% for the radiographical. And it is very high success rate after 1 year. So what is the percentage of teeth diagnosed with irreversible pulpitis and manifest apical periodontitis radiographically? It is interesting to see teeth with irreversible pulpitis and have an apical periodontitis in the radiograph. So Abilla et al. Answered this question in 2012, and they found that using periapical radiograph, there are 3.3% of teeth with irreversible pulpitis have a periapical radiolucency or apical periodontitis radiographically. And using CBCT, it was 13.7%, which is a very high percentage of teeth with irreversible pulpitis that manifest apical periodontitis radiographically. So from this, we can conclude that combining, you are as a dentist, you need to do you should take the history from the patient and you should take it carefully and see the details of history. And also you should do your clinical test to assess the pulp condition, and then you will do radiographs. Combination of information from all these steps only will give you the final decision. So if you take a radiograph and you did see an apical periodontitis sign in the radiograph, you will conclude that the tooth is non-vital without doing clinical sensibility test. So clinical sensibility tests, history are very important, as well as the radiograph. Because combination of information from radiograph, for example, you did have a periapical lesion or periapical widening, and the tooth, you did not do the sensibility test, you will conclude that the tooth is non-vital. So combination of these information is very important. That's why assessment of any outcome need to be performed according to these 3 categories or 3 parameters. The prevalence of AP lesion detected with CBCT was significantly higher in symptomatic group, because irreversible pulpitis have 2 categories, which is the symptomatic and the asymptomatic group. So does CBCT detection of PA lesion is histopathologically identical? So if we see a CBCT lesion, Is it a real periapical or apical periodontitis histopathologically? This has been answered by this study by Kanaga-Singan, which assessed the diagnostic accuracy of periapical radiograph and cone-beam computed tomography in detecting apical periodontitis using histopathological findings as a reference standard. So, so they did found that all imaging technique had similar specificity and positive predictive value, but in case of parallax view, we need additional parallax view and increase the diagnostic accuracy of periapical radiograph, and the CBCT has significantly higher diagnostic accuracy in detecting apical periodontitis compared to PR. So yes, if you did see a lesion in the CBCT, like in this picture, you can't see it in the periapical radiograph, but you can see it in the this lesion in the CBCT slices. And on histopathological finding, you can confirm that the diagnosis of CBCT lesion was an apical periodontitis. By the way, this study done on cadaver, which is dead bodies. So they cut the head of the body, and they section the jaws of a human body, of the human heads, and they perform the different radiographs, the periapical radiograph, the CBCT, and the histopathological or histological sectioning, and they confirm that if you did see a lesion in the CBCT, then it will present in the histopathological sectioning. And this done in Malaysia, because in England they can't do it. And the authors, one of them is Shannon Patel and Manocci, and both of them, they were in King's College London with us. This is my supervisor, and Shannon Patel is very well-known person in the field of CBCT. He got many publications, and Professor Manocci as well. So they needed to contact people in other countries to perform this study because the ethical approval problems. Why PA radiolucency present with irreversible pulpitis? The periapical inflammation precedes total pulp necrosis, and this results from a neurogenic inflammation related to bacterial products extending into the periapical tissue and causing a complex interaction of an inflammatory mediator, cytokine, and neuropeptide from the efferent fiber supplying the pulp and the periapical tissue. That's why we can see, or we see, a periapical radiolucency in some cases of reversible pulpitis or irreversible pulpitis. So the difference between partial and complete pulpotomy or pulpotomy, the complete pulpotomy procedure provides higher chance of removing infected and irreversibly inflamed tissue because we are removing all the coronal part and leaving the radicular part compared to the partial pulpotomy. And the magnification is no longer prerequisite in case of complete pulpotomy because the cutting procedure will be on a gross tissue, all the coronal part, and leaving only the radicular part. Chances of continuous bleeding is higher with partial pulpotomy because you are cutting part of the pulp, which may be a highly vascular, and this may cause continuous bleeding. So chances of continuous bleeding is very high in partial pulpotomy, but less post-operative response to cold test in teeth received complete pulpotomy because you are removing all the coronal pulp. So you expect a less post-operative response in the future compared with partial pulpotomy. Hemostatic agents that used in both procedure include sodium hypochlorite, which is an effective hemostatic agent and a valuable tool to assess the difference between irreversible and reversible inflamed tissue. And we have 2% calcium chlorhexidine and MTAD and 30% hydrogen peroxide as well, ferric sulfate, other hemostatic agent as well. The one point I need to focus, which is the last slide, is about the post-operative follow-up and recall. These cases of vital pulp therapy need to be followed up to ensure that the pulpal condition is healing and the pulp is healing and not develop to a necrosis, because developing to a necrosis of the pulp will lead to more complication, more apical periodontitis, and that's why we need to follow them. Procedure of following them should be periodically in order to assess pulp vitality, normal function, and apex closure in case of immature teeth. We should perform cold tests, electric pulp testing, and radiographs, which are essential and are excellent predictor for measuring success and survival rate. Follow-up also allow detection of emerging complications such as recurrent caries, poor hygiene, restoration failure, or cusp fracture. And the interval should be 1 month, 3 months, 6 months, 12 months, and then each year and go on. Thank you for your kind attention. I'm happy that you attend today for our lecture and for our discussion. Dr. Anas, the mic is yours, please.
Thank you very much, Dr. Ahmed.
Thank you.
God bless.
Thank you very much. Thank you.
We have a question from Professor Adel.
Yeah.
He asked you if you have a tooth to be used as an abutment for fixed partial denture. The tooth will, with irreversible pulpitis due to large carious lesion that involve pulp wound. Recommended root canal or partial pulpotomy?
No, partial pulpotomy, because even if the case complicated in the future, you can perform root canal treatment. Even if you did root canal treatment, you will not assure that there will be no apical periodontitis in the future, and you need a retreatment of the tooth. I think keeping the vitality of that tooth in particular, which is the abutment, is very important to withstand the occlusal forces occur from the bridge. So keeping vitality is advantageous and not detrimental for crown and the bridge work as for the abutments, because you will save the life of the tooth and will give the tooth more chances in the future to survive.
And don't you think that the preparation may affect the sensitivity of the tooth or may cause much more harm?
You mean if you don't have a space for retention, you mean? In that case, the restorability, if there is a problem in restorability and you need a retention, in that case, you should go for root canal treatment. But if you have a tooth with, you can do a restoration for it without need for intracanal retention mean. In that case, you can do vital pulp therapy.
Okay. I have a question, actually. If during your reviewing for the lectures, or sorry, for the literatures, you found any correlations between the like the tooth, whether it is reversible or irreversible, and the type of treatment, like partial or complete pulpotomy?
What you mean? Sorry, can you repeat the question?
If you have like a tooth or two teeth with a reversible and another with irreversible pulpitis, there is no any link in the literature which type of the treatment can be obtained, whether it is partial or complete pulpotomy?
Well, it's depend on many other factors. For example, the depth of caries. So if you get the caries and you remove it, and there is no exposure, in that case, you go with normal restoration. But in case of exposure,
yeah, so I mean exposure, yeah.
Yeah. So in that case, if the diagnosis was reversible pulpitis, you do direct pulp capping. But if the diagnosis was irreversible pulpitis, and you get an exposure, a carious exposure, in that case, you perform partial pulpotomy. And if the bleeding continue and the condition of the pulp is unfavorable, in that case, you continue until you perform a complete pulpotomy. And again, you assess the remaining radicular tissue. If it's favorable response to bleeding time and the color of the tissue, in that case, you do full complete pulpotomy. But if not, then you need to extirpate and do pulpectomy and followed by root canal treatment.
Okay, fair enough. Is there any question? Yeah, we have. What is the main difference between Dykal and MTA in terms of mechanism of action?
Well, it's maybe similar because calcium hydroxide depend on initiation of necrosis in the tissue, and this necrosis will followed by inflammation and healing. Minimum inflammation, not too it's not too large inflammation. So the MTA at the end of its setting reaction will create calcium hydroxide, and this will also initiate necrosis in the area and wound healing. The mechanism, the exact mechanism is not well known how these two materials work, but what is known that histologically, the dentine bridge created by MTA is much better than the dentine bridge created by calcium hydroxide, because the dentine bridge in calcium hydroxide is filled with tunnels that can act as a pathways for the bacteria to the pulp. And also the calcium hydroxide, solubility of calcium hydroxide represent a disadvantage and can make the pulp susceptible for bacterial ingress.
Okay. During your lecture, you mentioned that the biodentine produce a diffused calcification.
Yeah.
In one of the literatures. What they mean about diffuse calcification?
Well, the problem is that if you got calcifications in the pulp, mean that there is like pulp stones or calcified tissue is not confined to the dentine bridge, but it's extending into the pulp chamber. So they did found that some of the calcification in these cases. And the study I have mentioned, which is by Dania, she did a biodentine versus glass ionomer cement in teeth with deep caries and reversible pulpitis. And she did indirect pulp capping. And after doing biodentine and GIC and follow them for 1 year or 2 years, she did find that there is a calcified tissue on the dentine under the fillings of biodentine. So biodentine initiate more calcifications in the dentine or in the pulp that could be manifested radiographically.
Okay. Actually, I have some cases and clinical cases that I found for the defective fillings that I've used. In the first filling, I've used the calcium hydroxide, and when there is some defect in future, when I remove the old restoration on the pulp, like the cement and the calcium hydroxide, and there are some caries, I'll go for drilling much further. I couldn't find the canals, like there is a calcification for the whole pulp chamber. This is what I face in my clinical work.
Yeah, that's sometimes may happen.
Okay, so it's there is no, like in the literature, I've read also many literatures in the same subject. None of the studies tell now understand what is the mechanism for this, and even what's the kind of the tissue which is formed. Some call it like it's osteoid-like tissue. I mean the reparative material.
Yes.
Calcified reparative.
Yes.
Yeah.
Yes, that's right.
And even it's I also have some like in my work in the PhD, the reparative dentine, which is formed near the pulp, it's like a plug. So it's atubular. In order, I explained that it's that the cells of the pulp want to close the path of the bacteria or any pathogens during the tubule. So they make like a plug similar to the clot, but it's a calcified tissue. And then if there is some cells still vital of the odontoblast, they start to form a new tubules, which is, I called it secondary tubules.
Interesting.
Because I followed the cycle of attrition in rat molars in different ages, and I found like this interesting story. So we have some questions from the audience. We have a question here. Sorry. Many of them, thank you for your interesting lectures.
Thank you.
One of them asked, what is the best material for direct pulp capping?
Well, for direct pulp capping, probably is the calcium silicate cements.
Okay.
Which will include many brands in the market.
Okay. And there is another question: how many weeks give for patient to do the permanent filling after both Dykal and MTA?
Well, you can do the permanent filling directly at the same visit.
Oh, sorry?
You can do the permanent filling directly at the same visit.
At the same visit, okay.
It will be much better because it will seal the restoration permanently and prevent ingress, not just like the temporary filling, which can leak and causing a failure of the capping procedure.
Okay. Dr. Adil have something to add about your answer for his question. He said, sorry, Dr. Ahmed, I don't agree with you. Pulp cap teeth, the teeth used as a bridge abutment has a higher rate of pulp necrosis than any other tooth type.
Yes,
so this is
probably. Yeah. Probably that. It's better to do implant rather than do crown and the bridge.
We have this is what we have in our courses like this. It's it's just throwing ideas. It's
of course,
yeah, we are believing in 100% to what we have in the literature, because
the problem, the problem with dentistry, you think you are treating a problem, you're solving a problem, but you're causing another problem.
Yeah, of course.
Yeah.
This is our life. This is our job.
You try to solve some problem, but you're facing another problem. You're causing another problem.
Yeah. For the survival of our clinics. This is very important.
This is it's a very interesting approach in research. They approaching the outcome of dentistry now from two perspectives. One is from dentist perspective and one from patient perspective. So what you see it as an adverse effect, the patient doesn't see it an adverse effect. You can see it on histopathological level, but for the patient, it doesn't make any difference. He needs just a tooth to serve in his jaw.
Yeah. So I think our time is nearly run out. We still only have 30 minutes. So I think we have done today. What do you think, Dr. Ahmed? Or do you want to open discussion for?
Yeah, of course. If there is any of the attendee want to comment or add something, it will be good. So just raise his hand, and we will open the speaker for him and the mic, and he can speak whatever he want in Arabic or English in as he like.
So we have a question from Prof. Hussein Al-Ahwazi. He said, if we use material to produce dentine cap in vital pulpotomy, there will be sclerosis of root canal, which will make endo in the future more difficult.
Yeah, it's not all the time. It's still under investigation, this phenomena. But all the clinical studies I have cited, they didn't found this problem because they follow the patient for 1 year, 2 years, 3 years, 4 years, and there was no problem in the patient, and they did not report any problems.
Yeah, could be.
But it's happening. It's happened sometimes. Yeah.
Yeah, this is what I asked you about.
Yes.
Or add about the calcium hydroxide.
Yes.
Yeah, cases taking more time than 5 years. So I often found some calcification, and it was difficult.
To open it with the files.
Yeah. But I think there's another way for the thinking in here. If you have a case which may survive for maybe 10 years, then you will face a problem of calcification. If you did your endo at the first time, I don't think the case will survive for 10 years.
Of course, you will face the fractures of endo, face other problems, face secondary infection. It's like a cycle. It's like a cycle of life of the tooth.
Yeah. So if any of the audience want to for us to open the mic for him,
yes,
just
please
write in the chat. I want to add something, and we will open the mic.
Chat or raising his hand. We will. Yeah, Dr. Samer. Yeah, I will. Yeah. Okay. Just a minute. Sorry. Ask to unmute. Yeah.
By the way, Dr. Ahmed, there is a problem in the link of the registration. So I asked the audience to write their name on the chat box.
That will be great. Okay, no problem.
Yeah.
سامر yeah you can
تسمعوني دكتور؟
اي نعم دكتور سامر تفضل.
السلام عليكم جميعا.
عليكم السلام
دكتور محاضرتك
الله يحفظك ويخليك. الله يسلمك.
أمانة محاضرتك كانت highly leading. أنا ما أخفي عليك يعني كثير من from my attitudes about treating tooth with deep-seated caries might shifted for some extent.
الله يحفظك.
My clinical performance might be changed. يعني the summary that I get from your informative presentation and this wide and inspections of information about the subject, you illuminated us about how to treat pulp. النتيجة طلعت بها أنه we might treat the pulp as conservative as we treat the dentine, since once we have the ability to preserve the dentinal tissue, we have to do the same for the pulp.
Exactly.
So we always we use to treat the deep-seated caries, as you mentioned before, from our perspectives as a dentist rather than the patients. We do treatments that we guarantee its success for a high rate, since root canal treatment is highly successful from the clinical point of view. But now I might shift to more risky areas by treating the patient and inform them that we might need in the future a further treatments if something goes wrong or our treatment is not fully successful. أعتقد هذا موضوع يعني قد يكون خطر بالنسبة لبعض الأطباء، لأنه هذه السنتنس بالنسبة للبيشنت يعني قد be shocked him. هو يريد يسوي الشيء ويخلص خلاص. He wants a guarantee from his dentist and nothing would goes wrong there. But some of the patients might be with a little bit motivation and information, he might understand what we are doing. So we need first to lecture him with a few sentences about the benefits of such treatment, considering not removing the pulp, the whole pulp, and doing root canal treatment. بالنسبة لمداخلة يعني دكتور حسين، احنا اكو كثير من استاذنا الفاضل دكتور حسين الحويزي، عندنا كثير من الموروثات في فكرنا اللي هو موضوع المورفيكيشن، او عفوا احنا نسميه مورفيكيشن، هو البulp كابينج او البارشال ريموفال اوف ذا pulp. It's يعني not well reputed site of treatment by other dentists. يعني من نشوفه نعتقد أن هذا الطبيب did something wrong. He need to do whole root canal treatment. هذه بالنسبة مشكلة تعتمد على ال attitudes of the community, both the dentist community and the patients community. أعتقد هو موضوع الكالسيفيكيشن، إن كان حدث الكالسيفيكيشن ف it's the causative of living tissue. يعني the pulp is still living بحيث هو has the ability to bridge the openings ويصير calcification. So I don't think يعني برأيي القاصر أنه once there is a calcification within the canal, then there is a living tissue we have to preserve. فيعني ما أعتقد البوسيبيليتي يعني يصير مستقبلا عندنا periapical lesion هو سبب this type of treatment، ولو أعتقد الموضوع needs further يعني investigation في سبيل أن نصل إلى يعني نغير our attitude. مرة ثانية دكتور أنا أشكر جهودك الواضحة، وطبعا جهود الجميع، حضرتك ودكتور أنس، يعني كانت الدورة يعني ممتازة. زين، حي جهودكم إن شاء الله، وإن شاء الله الجاي أفضل وأحسن بوجودكم ووجود الجميع طبعا.
شكرا
وممنون.
دكتور سامر، شكرا على المداخلة اللطيفة إن شاء الله. ويعني صراحة حكيك تمام مضبوط كله، لأنه البيشنت يحتاج موتيفيشن. تمام، الموتيفيشن سهلة من ناحية الكوست effectiveness، من ناحية explaining for the patient what the consequences that he need to follow in case of doing root canal treatment. He need to crown the tooth and to perform extra measures. But the problem with both aspects of treatment, we are, or as you say, the dental community is afraid of doing vital pulp therapies because of unpredictability, because you can't predict the outcome of the treatment. But in my opinion, it's not about the predictability, it's about the onset, the short onset of signs and symptoms that could appear during your treatment. So in case of root canal treatment, you will need years to see the failure. But in case of vital pulp therapy, the failure could appear instantly. So because you have the chance to hide a problem and it will not appear on the surface, you consider it as a successful treatment. And it is successful in the indicated cases. But if you have the ability to preserve the pulp, that could be high chances of success. But the root canal treatment is a well-established treatment and have a good high success in many cases. but it will make the life of the tooth shorter because you are jumping into more extensive or more invasive approach, which need precautions, more precautions to make it more successful.
هو بالفعل دكتور تعقيبا على كلامك احنا يعني nowadays مش اعتقد يعني شخصيا مشكلتي الاساسيه هو with the survival rate of the tooth even after doing well done root canal treatment. I'm not concerned with the early results. I want to make this type of treatment functioning as long as possible. The mechanical failure of the tooth due to يعني excessive removal of tooth structure, this is my concern. The patient, you know, 5 years survival, 7 years, 10 years. Nowadays, with the advancements of the treatment modalities we have in dentistry, introducing the dentistry over years, made the 5 and 10 year survival is not enough. We need a longer success rates. We need to preserve the tooth for longer period of time without need for adding new treatments or retreatments after a while. يعني بالنسبة لنا المريض يعني نسوي له حشوة الجذر we reconstruct the tooth after doing root canal treatment, and we are putting in mind that after several years تطول المدة أو تقصر راح يحتاج another type of restoration. There is some sort of breakage in some aspects of the tooth وهكذا. فيعني هو متى يصير علاج زين فتشي نسويه ونخلص من عنده وخلص ننساه؟ لا، هو دائما عندنا we have to do a follow up نحط ببالنا حتى مع مجهود يعني جيد وماتيريال ممتازة وتكنيك perfect almost perfect، لكن مع هذا دا يصير عندنا انه المريض ورا فترة يعاني من مشكلة إضافية بالسن، فهو وكأنه عندنا يعني حرب طويلة الأمد نقاتل بها سايكل في سبيل نحافظ على السن.
صحيح.
we always happy with يعني أن نفكر بطريقة مختلفة بحيث أنه we preserve the tooth for a longer time, we maintain its vitality باعتبار أنه هذا البulp tissue it's a wonder by itself and has a rule. يعني هو ما موجود على مود احنا نشيله ببساطة. هو أكيد له وظيفة وهدف، أهداف عديدة، قسم من عندها عرفناها by research وقسم من عندها قد تكون بعدها needs further investigation to know it. يعني we have to put in mind that it is always beneficial to have a vital pulp rather than non-vital pulp.
صحيح كلامك صحيح. شكرا. العفو. دكتور حسين تفضل حضرتك open mic.
Thank you very much. Thank you very much for the good lecture.
Thank you.
I just want to point out that a couple of weeks ago I posted a case of a lower 7 whereby I did 5 years ago vital pulpotomy with MTA, and it was successful.
Great.
But the criticism that I got from my colleagues when I posted the case is that why did you ever leave the mesial canal vital pulpotomy and you did the distal endo? I was very happy with my treatment because after 5 years I got good results, and it was the root was vital. But when I saw the X-ray, there was minimized root canal space, and there was sclerosis in the apical region, and this is a normal procedure. Because we're talking about reparative dentine. Whenever you play, this is not normal secondary dentine that's being formed. It's a reparative dentine, which is around about 3 to 4 times the amount of dentine being deposited. So you would expect in the future that the space of the root canal is going to be rather more minimized. So in order to evaluate the case, you have to evaluate it as a whole. You go for vital pulpotomy, it's nice, it's okay, but you might end up with a minimized root canal walls, which will be in the future a problem if there is new caries happening in the tooth itself. I mean, there's something new, not alone, and it makes pulpitis and any other new. So that means you will end up with a very difficult treatment, because you can't do endo treatment if it's completely sclerosed. This is what I wanted to point out. At the end, thank you.
That's right. That's right, Dr. Hussein. The point here is that the dental treatment need to be complete in the essence that if you are pointing that you need to do vital pulp therapy for the pulp, then at the same level, at the same weight, you need to consider a good sealed coronal restoration, whether it's composite adhesive resin restoration, or crown restoration, or other types of treatments, or inlay only. But the job of coronal restoration is as important as the vital pulp treatment. So either in root canal treatment or in vital pulp therapy, in either case, we need to do a good coronal restoration. So in case of root canal treatment, the coronal restoration are important to prevent ingress of bacteria. And in case of vital pulp therapy, the coronal restoration as well important to prevent ingress of bacteria. So the problem is in coronal restorations. So in order to prevent any future danger to the pulp cap teeth and prevent the complication you pointed, which is the calcification, and prevent the dealing with these complications, so in that case, we should focus to prevent future complication through the coronal restoration. If we manage to seal coronal restoration and provide a good coronal restoration, in that case, we will have no problems from the side of the roots. But in case of root canal treatments, we have two sides, which is the radicular part and the coronal part. And both of them, we need to have a good sealing. So in the radicular part, we need to eliminate all the bacteria and ensure a tight seal in the apical area. And at the same time, in the coronal restoration, we need to ensure a good coronal restoration. But in case of vital pulp therapy, in the apical part, there is no fear of leakage or fear of any problem, because it's already vital, it's compatible, it's a normal tissue of the body. So yeah, calcifications of the canal may be a problem, but as I have said, clinical trials that I have seen, they did not report that, but it's documented in some other studies or other papers that there is some evidence for calcification in the canal. So I think coronal restoration is very important in both types of treatments to prevent any future complication to the both treatment, whether root canal treatment or vital pulp therapy. Thank you very much. Is there? Yeah, thank you. Is there any other participant they want to participate?
There is a question, Doctor.
Yes, please.
It's about from Dr. Sharif about interesting information.
Thank you.
His question is about the efficacy of using resin-containing material such as Dykal as compared with biodentine and MTM partial pulpotomy.
There is no comparison between them. Dykal containing about 45% of resin, which is very toxic to the pulp tissue. And studies found that Dykal is detrimental to the health of the pulp because it contains resin, and the resin is toxic to the pulp tissue. So there is no comparison between biodentine and MTA and Dykal.
Okay. I think we don't have anything left.
Yes.
Okay, there is a question also, sorry. How we can decide that radicular pulp not inflamed after complete pulpotomy?
Sorry, can you repeat, please?
How we can decide that radicular pulp not inflamed after complete pulpotomy?
Well, because we see for the orifice and the canal, if the bleeding is continuous and the condition of the remaining pulp tissue is unfavorable in terms of presence of necrotic area, which show no bleeding or a continuous bleeding from the radicular part, in that case, we expect that there is an unfavorable condition of the pulp and we should do pulpectomy and remove the whole pulp from the radicular part. But if we got a red pulp tissue that does not bleed continuously and the bleeding stops after irrigation with sodium hypochlorite, in that case, we consider that the pulp is normal tissue and we should cap it with the capping material. So we depend on intraoperative assessment during our treatment.
Fair enough. ما أعتقد بقى عندنا أي سؤال من الحضور. نعم. وصلنا إلى نهاية الكورس. الحمد لله. إن شاء الله تكونون استفادتوا جميعا. شكر خاص جدا إلى المحاضرين الأستاذ الدكتور حسين الحويزي. محاضرة الشيقة كانت في يوم الأول وختامها مسك مع دكتور أحمد حامد.
أشكرك.
في هاليومين كانت محاضرات أكثر من رائعة. وشكر إلى عمادة كلية طب الأسنان والشكر الخاص إلى الأستاذ الدكتور رغد الهاشمي عميد الكلية. وإن شاء الله تكونون استمتعتوا بالمحاضرات. أحب أذكر أنه يوم غد يكون الامتحان الخاص بالدورة، راح يكون فورم مال لينك الأسئلة راح ينزل على الصف الإلكتروني. يعني شيرت اللينك مال الدخول للصف الإلكتروني، فإن شاء الله راح تنفتح الأسئلة في نفس الوقت في ساعة 8 ليلا. مو دكتور أحمد؟
أي نعم، الساعة 8 بالليل إن شاء الله. الموجودين على الصف اللي داخلين بالصف راح يشوفون أكو إعلان باللينك ويجاوبون على اللينك.
راح نبقيه مفتوح ايش قد دكتور؟ ساعة؟
الامتحان لمدة ساعة.
اي نبقيه مفتوح اللينك لساعة إن شاء الله، وبعدها يعني ما راح يستقبل الإجابات، راح يكون مغلق ورا الساعة. ويعني إن شاء الله ما تحتاجون أزيد من 5 دقائق، يعني لا تخافون، بس هو اللينك مفتوح. إذا حد يحضر بالتسعة 8 العفو يحضر 8:30 ويملي الأجوبة إن شاء الله. ونشكركم على سعة صدركم وحضوركم هذا خلينا نقول الحدث العلمي الخاص بفرع معالجة الأسنان. وإن شاء الله نشوفكم بالدورة الثانية اللي راح تكون يوم 5/5. راح تكون خاصة بالتوبكس اوف كراون اند بريدج. راح يكونون أيضا 4 محاضرين من الفرع. إن شاء الله تكون محاضرات أيضا شيقة في مجال الكراون اند بريدج. شكرا جزيلا لكم، وإن شاء الله تصبحون على خير وفي أمان الله.
شكرا جزيلا دكتور أنس، مع السلامة، شكرا للحضور.